Good afternoon, good morning, everybody. This is Dr. Leon Scott. I am going to go over a lecture, a didactic on understanding diagnostic studies. For our upcoming journal club, we will be reviewing a diagnostic study and learning how to critically appraise them. To do that effectively, we need to understand them more. With the presentation that Cody gave on his chapters for the epidemiology text that Dr. Kuhn has given everybody, it stood out to me that there may be an opportunity here to better understand how cross-sectional studies work and diagnostic studies specifically. So this is the beginning of a slideshow. Hopefully not too long. It is 30 plus slides, but we'll keep it moving. The objectives here are to understand the difference between cross-sectional design and observational or treatment or prospective or prognostic design. My talk will go over the difference in levels of evidence for these two different groups of studies, and then we're going to practice it during Journal Club, but we'll introduce a little practice here too. There are two main categories, the way I see it, two main categories of papers that we review. And there may be more, but for this model, thinking about it this way is helpful. There's what many of us are used to, the idea of a treatment study or observational study, a prognostic study. And then there are cross-sectional studies. What is the difference? Time is the difference. With an observational study, we're looking at one patient over time. Now, we're looking at a group of patients potentially, but for anyone who is involved, we are watching them over some period of time. For the cross-sectional studies, we are looking at one patient right now. Now, these studies can take years also, but that's because you're collecting enough patients, but all the information you're capturing from that patient is information from that day in clinic. Now, there are exceptions. Maybe they're getting a blood draw and you're measuring something in their serum, and then when the serum test comes back the next week, you do an MRI on them. So yes, it may happen over a short period of time, but effectively it is all happening right now. So that is how I like to split up studies, looking at subjects over time, looking at subjects right now. So what are some of the cross-sectional study types? Well, before we jump into that, it's helpful to understand a few terms. I will be using the term population and the term sample through this presentation. A population is a complete group of people. Now, that could be a big population, like the population within the Danish health registry, because all their patients or all their citizens are registered within their nationalized health system. So maybe we're looking at a whole country's worth of data. But a population can also be all of the people who come into my clinic in the month of October. As long as it is consecutive and you're making efforts to capture everyone, that's a population. A sample is just a little piece of that. So they are non-consecutive groups of people that might be hand-picked from a population or randomly sampled from a population. So that's a difference between a sample and a population. Not really the size, but is it a consecutive group of patients or subjects as compared to a non-consecutive group? When we are looking at prognostic studies or observational studies or treatment studies, we are looking at groups over time. And I used a confusion matrix here, that 2x2 matrix, and I'm using that little signal for a sample here with those puzzle pieces. So a sample of subjects in group 1 and then in group 2, and then we're tracking over time and seeing what the outcomes, did an outcome occur within this group as indicated with the letters. A diagnostic study isn't looking at things over time. You are looking at a population, hopefully, and in that population there are people who have a diagnosis identified with a gold standard. And at the same time, you are running a test and seeing how the presence of a positive or negative test associates with the presence of a gold standard diagnosis or not having a diagnosis. There are levels of evidence for the treatment, prognostic, observational studies, and from here forward I'll just call them observational studies. And these are the ones we're classically familiar with, so I won't go through them, but there is also a description of levels of evidence for cross-sectional studies. I won't go into full detail here on all of these, but levels of evidence 1 and 2 are consecutive groups. Level of evidence 3 is a group that there was a non-consecutive collection of data. Perhaps people only got a gold standard if their screening test was positive. Then there are case controls, which are looking at a group of people with and a group of people without a diagnosis, and then seeing if a test is positive or negative. And then case series. So really we're just kind of using descriptive statistics in a case series. And that is level of evidence 5 in terms of diagnostic papers, but it does have some value. Specifically, if you're doing a case series of a whole population, what you're doing is measuring the prevalence of a finding. How many people in the United States above age 40 have a meniscus tear? Well, you do hopefully a population study, but it might be a sampling study just because the US is a big country. But you gather that information and you don't have anything to compare it to because it's a case series. So you're left with what we call pre-test probabilities. Of everyone over age 40, there is a percentage of people that have meniscus tears, and I believe the pre-test probability is about 15% of people who have clinically significant meniscus tears after age 40. Or at least an estimate of that, probably from a sampling. So that leaves you with the prevalence of a finding in a population, or its pretest probability. We also can take a look at a population or a sample, and instead of just measuring a finding, we can use a gold standard to define the presence or absence of a disease within that population. So on this 2x2 matrix, we can see that the column with A and C is diseased and the column with B and D is not diseased. And at the same time, we run another test. So we use a gold standard, perhaps a biopsy to identify a certain tissue pathology, like the fibrosis seen in adhesive capsulitis, and simultaneously we measured the volume of fluid in their arthrogram. Is there an association between the fluid volume that a shoulder can hold during an arthrogram and the pathologic presence of fibrosis in their capsule? Well, when you look at a population of individuals who are coming into your office with complaints of shoulder pain, then you can potentially perform that test and see what the test characteristics are. So let's in fact do that. Let's look at this matrix, and I'm just going to change the colors for a second here. We're going to make them red and blue. And the reason we're doing this is because we're going to look at some figures that in a moment represent the distribution of individuals in a population. Now, what we want to see in a diagnostic test, this rarely happens, but what we want to see is that the two groups are so different that there's hardly any overlap. Oh, that's real easy. We know exactly where the cutoff should be, just between the red and blue curves that if we could have a diagnostic test that has a threshold there, we'd be pretty much set. But we know that's not how the world works. Usually there's overlap where individuals that do and don't have a disease may have certain findings that the values for those findings overlap. So we draw a line in the sand. We say that a certain range of motion or a certain laboratory value or a certain collection of findings creates a diagnosis, and we draw that line in the sand, and here we are. Now, if the red group is the diseased group, then the true positives are the individuals on one side of that threshold. The false negatives are the diseased group that are underneath that threshold. You see that little, the blue behind? Well, we have the false positives. This is the group of individuals that don't have a diagnosis, but they are above a threshold. And then we have our true negatives, which are the individuals without disease that are below that threshold. That combination is represented in the confusion matrix, that 2x2 matrix. And we can look back at the letters, but also substitute them with those abbreviations, the true positives, the false negatives, the false positives, and the true negatives. Now, as we've all learned before, the test characteristic called sensitivity is going to be that true positive over the collection of true positives and false negatives. And visually that looks like this. And the specificity is going to be the true negatives over the collection of true negatives and false positives, and visually represented here. Now, these values alone can be very helpful, but when we combine them together, we can get something called a likelihood ratio. And when positive, the likelihood ratio is something you can multiply by pre-test odds to get post-test odds. Similarly, with a negative likelihood ratio, this would be less than 1, and when multiplied by the pre-test odds, it decreases the post-test odds. Please look at the diagnostic information sheet and critical appraisal sheet to see this in more detail. Now, we can use this, but before we do, I just want to point out something very important. When we are measuring sensitivity and specificity, it is my position that this should only be reported when there is population data. Because if we are looking at everybody that comes into my office with shoulder pain, and I'm searching for adhesive capsulitis, for example, I should not be excluding everyone that has a rotator cuff tear and a trauma to their shoulder instead of a non-traumatic shoulder pain. Doing that type of manipulation creates verification bias and filter bias, which are diagnostic studies versions of selection bias. So we need to be very careful of that. And the reason why is because if you remove those things, you are altering significantly the non-diagnostic group, and your positive test may have been positive unknowingly in the group of people that you excluded, even though they did not meet the gold standard for the diagnosis you're looking for. So you can get biased or falsely elevated or decreased test characteristic results. This is an example of a small population in identifying sensitivity, specificity, likelihood ratio, both positive and negative. Pause the video here so you can look through this and see if you come up with the same results. All right. I'm going to jump into something that's important for our journal club, and that's case control studies. Now, these exist in both observational and cross-sectional studies. And for observational, you're going to look back and see if someone had an exposure in the past that progressed over time. Instead, we are going to see case control studies that are looking at the presence or absence of a finding at the same time as the gold standard. So that is why case control studies can be both observational and cross-sectional. So where it says exposure and no exposure, just imagine that says test positive and test negative. Okay. Now, if we have the same looking confusion matrix, but the difference is we have a group of people with a diagnosis and then a matched group, which is a form of manipulating a group, a matched group for comparison that doesn't have the diagnosis, it looks very much like our other cross-sectional studies where we get where we can calculate a sensitivity and a specificity and other test characteristics. But before we jump into that, let's just remind ourselves that we can do a number of different counts with case control studies, one of which is the odds. See that at the bottom there? A to B. So the odds that having a exposure here or a positive test, the odds that someone who has a positive test has the diagnosis or doesn't have the diagnosis would be a measure of, it's not probability here, it truly is just odds, but a way of measuring the chances of something being present. Below that we have the no exposure, or just imagine that says a negative diagnostic test, and the odds of a group that has a negative test having subjects that have the diagnosis or don't have the diagnosis is C to D. Now, when we look at that, we are familiar with the idea of an odds ratio, which is one set of odds over another set of odds. So what are the odds that a person with a positive test or a group of individuals with positive tests will have a certain number of individuals with a diagnosis compared to a certain number of individuals without a diagnosis, as compared to a whole nother group of individuals who have a negative test? And what we can create there is an odds ratio. The possibility that having a positive test is positively associated would have an odds ratio that's above 1, and its confidence intervals would remain above 1. The opposite would be the odds would be negative or less than 1, or the odds ratio would be less than 1 if having a positive test had a lower odds than a group that had a negative test. Now, because it's a 2x2 matrix, many people think that they can just do a sensitivity specificity evaluation, which would be A over A plus C and D over B plus D. But you can see how mathematically that is not the same as an odds ratio. So one of the things that we'll be looking at is when a paper reports a sensitivity and specificity, should they report that, or should they report odds ratios instead? So that's one of the things we'll be appraising and looking into critically during this upcoming journal club. Hopefully this was a brief but also helpful review of cross-sectional studies, specifically diagnostic studies. Please refer to the diagnostic study critical appraisal sheet for more information that fills in the gaps.